team.
All right. So hi, everyone. I'm Courtney Campbell. I'm a cardiology fellow at The Ohio State University and work closely with Dr. Daniel Addison, who is co-director of our cardio-oncology program here. And we are thrilled to be invited to present cardio-oncology in the era of COVID-19, a transcontinental perspective. And we will be talking a little bit about our perspective as well as Arjun K. Ghosh from St. Bart's. We'll be talking about his experience in the UK. And we've also invited Dr. Jen Woyach, who is one of our oncology specialists at Ohio State, to provide a little bit of her experience as well and add in the oncology side of things for cardio-oncology. So first, we have no disclosures. And to give you a brief overview of what we'll be presenting, we'll be talking about cardio-oncology and COVID and discussing two papers that we recently published, one looking at cardio-oncology practice changes, and then another that grew out of that initial paper looking at drug repurposing, particularly cancer drugs, against COVID-19 in clinical trials. Then we'll look at the US perspective, and really we'll be providing the Ohio perspective because that's what we have experienced, and then a brief case discussion. And then Arjun will be talking about his UK experience. So with that, Dr. Addison will begin looking at patients with cancer.
Thank you, Dr. Campbell. That's a great introduction. So to give a little bit of backdrop, amongst patients with cancer, we have found that over the last several months with the experience during the pandemic, it's very clear that cancer patients are more vulnerable to COVID-19 and adverse outcomes. In initial studies from China, patients with cancer had an increased incidence of COVID-19 nearly threefold compared to those without cancer. This was also more likely to associate with a more severe adverse course amongst these patients, with severe clinical courses being noted in 39% as compared to 8% with rapid deterioration earlier amongst cancer patients than otherwise. In a meta-analysis, cancer patients were shown to have an odds ratio of 2.29 compared to non-cancer patients of having more severe COVID-19 complications. In studies from New York, similarly, increased fatality rates were noted amongst cancer patients, with 25% in solid tumor patients and 37% amongst hematologic malignancy patients. In the Sloan Kettering experience, 20% of cancer patients with COVID-19 developed severe respiratory illness and 12% died within 30 days, with age greater than 65 and immune checkpoint inhibitor use being predictors of more severe disease and outcomes. Amongst the Italian experience, prostate cancer patients on androgen deprivation therapy were at lower risk of COVID-19 infection, however. Next slide. Notably, because of the recognition of the vulnerability of cancer patients to adverse outcomes related to COVID-19, over the last several months, there has been a consortium that's been formed within the US experience. And within this, the Cancer Consortium, COVID-19 and Cancer Consortium cohort of well over 120 participating institutions, we have found similar, or begun to note similar patterns in terms of outcomes amongst cancer patients. However, this consortium may allow for future delineation of more clear risk factors and potential treatment or therapeutic strategies. Next slide. Within all this, though, as many of us know, we've also recognized that that COVID-19 patients with underlying cardiovascular disease tend to also be more vulnerable to adverse outcomes with COVID-19. Initial studies from China demonstrated that 35% of patients with underlying CVD were more likely to have elevated troponin, specifically 54% compared to 13%, and that elevated troponin associated with more severe adverse outcomes amongst patients, with nearly a 7 to 8-fold increase in adverse outcomes and/or death amongst these patients. And specifically, the odds ratio for those with underlying CVD was 5.2, with hypertension alone showing a 2.7 odds ratio as well. Next slide.
Oops.
Oh, maybe we'll go back one slide. Here I'll let Dr. Campbell also join in as well and present the next slide.
Sure. Well, first I wanted to pause and see if Dr. Woyach had anything to add about the cancer experience with COVID-19.
Thanks, Courtney. I just agree with everything that Daniel mentioned. I think one thing we've noticed is that most of the data, well, actually very similar in terms of outcomes, does come from the hotspots during periods where they just had a lot of cases and in many cases kind of overwhelming of their systems too. I do think that our experience has been a little bit less in terms of mortality, and hopefully that's something that is seen in other institutions as well. But definitely those patients with cancer, and coming from a hematologist perspective, especially our patients with heme malignancies, those that are older or those on active therapy, really do have very poor outcomes.
Great. Thank you, Dr. Woyach. All right. So I think all of us in the cardio-oncology community really recognize the particular vulnerability of our patients between both the oncology aspect and the cardiovascular disease. So I think JACC Cardio-Oncology was the first to come out with 3 publications looking at coronavirus, the clinical trials, cardiovascular disease and cancer risks, and then the role of telehealth. And then we've been pretty prolific in discussing COVID and cardiovascular disease with different editorials, viewpoints, reviews, letters to the editor. And then, of course, ICOS just this last week has put together a fantastic statement looking at cardio-oncology care within the pandemic and very specific recommendations for how to handle particular toxicities and best practices for monitoring. And so what we'll discuss now is the paper that I had the privilege of working on with Dr. Addison, Dr. Guha, Dr. Ghosh, Dr. Dent, looking particularly at some of our initial recommendations. And part of this was recognizing that these patients were at increased risk, but like Dr. Woyach said, a lot of these were related to the hotspots, and that some of the downstream consequences are much more in systems management and things along the lines of just care disruption. So delays in diagnosing cancer because screenings are delayed. Issues with cardiovascular patients not presenting to the hospital with acute issues. And I know we saw a lot more delayed complications of myocardial infarctions within those first few months, especially like April and May. And then also just access to care. So there's issues economically with people being not having insurance coverage, unable to pay for drugs and things along those lines, medications that we prescribe. And all of these have really transformed and changed the way we've thought about things. And so one thing that we put together was an algorithm to try to help mitigate the risk and highlight ways we can better serve our patients. So we thought about ways that patients typically present to cardio-oncology. So it's either a new patient with cancer diagnosis and is found to have a potentially higher risk of cardiovascular complications with a known cardiovascular history, symptoms that might be cardiovascular, or risk of cardiovascular toxicity related to the planned treatment. Also, for cancer survivors, we might get referrals through survivorship clinics and primary care physicians that have potential cancer therapy complications or be at risk of developing those, such as hypertension, arrhythmias, or cardiomyopathies. So what we envisioned was having most likely a cardiac triage process through someone within the cardio-oncology clinic staff that's able to put together labs, biomarkers, historical data, risk of therapy, and triage, at least for a virtual visit, which patients might be better seen by a cardio-oncology physician versus a nurse navigator. And those with kind of undetermined risk we thought might be better served seeing a nurse navigator because they could help with getting a little bit more history or seeing what kind of data we might need to help make decisions, getting records, because at least at Ohio State as a tertiary referral center, we rely a lot on our community partners and hospitals and local hospitals and local care to help inform our risk management because a lot of our patients are 2 and 3 hours away. So their cardiologist that's been taking care of them for 5 to 10 years has all of their records. And then based on that cardiac risk assessment, we would then be able to decide if an in-person visit was warranted or if they could continue seeing us in a virtual setting. And then the other thing for virtual visits is we are able to now see our patients at home, in the car. It really limits the amount of times they need to travel, like I said, 2 or 3 hours for a single visit. And then potentially overlapping with infusion visits if it's a relatively quiet session to be able to have our virtual visit. So I wanted to see if Dr. Addison has anything else to add on to that.
Yes, and again, I think I would only echo the words that Courtney has given. I think really kind of streamlining the process, embracing the telehealth aspect is vital amongst patients with cardio-oncology more than ever. Just as, and I think the illustrious Dr. Jennifer Woyach, I think we may have understood here from their side, seeing cancer patients and understanding their vulnerabilities to COVID-19 only forces us to act with more standards as far as how we care for these patients. And so I think really just thinking about ways to minimize the number of excessive screening visits, excessive studies, and overall excessive in-person assessments is really the most optimal way to care for these patients.
So I'll move on to our other figure from this paper. So this is how we envisioned the phases in cardio-oncology care during the pandemic. And really it has to do with our healthcare resource utilization. And especially at the peak for us, a lot of our resources were devoted to the COVID pandemic and less to non-pandemic care. So things like personal protective equipment at the beginning were in high demand, and that really changed what procedures and testing that we did. And so for things on the cardiovascular side of aspects, we were doing caths only for ACS, only emergent cardiac imaging studies. We shifted a lot to CT if we needed to look for like an atrial thrombus rather than an invasive transesophageal echo. We did a lot of really focused echocardiograms and a lot of e-consults. So especially in the first few months, if we felt that we could effectively advise and answer a consult question electronically with either over the phone or a video on an iPad in the room, we did that. And a lot of things were paused on the clinical trial side of things. But now I think we're towards in a recovery phase, at least in Ohio, and have much more, doing a lot more imaging studies, and things have changed a lot along those aspects. And a lot of the triage has gotten lighter. We're able to do more studies on a daily basis, and we're doing more clinical trials and opening that up. And then for moving forward on the recovered side of things, the telehealth visits, and I think are here to stay. And we definitely still incorporate those, especially for people traveling far away, and have much more, at least on the cardiovascular side of things, wide open as far as indications that we're doing these procedures. And I'll talk a little bit more about specifics for our hospital. But I think it's important that this graphic shows is that it really is a moving target, and depending upon the local outbreak levels, the ebbs and flows on the hospital resources availability is really going to determine how things go for us. And then with that, so cardio-oncology, some of the considerations. we spoke more about in the paper, is we really have a lot of experience directly related to COVID-19 for hyperinflammation and CAR-T, immune checkpoint inhibitors, and this helps a bit when it comes to the treatment of COVID-19. And we'll talk a little bit more in the upcoming slides about cardiotoxicity vigilance when it comes to repurposing therapies. I think the next phase for us is going to be helping advocate for our patients to ensure that they have access to COVID-19 immunizations when those vaccines hopefully start to become available in the next few months. And I think this has really underscored the need for continuing to do cardio-oncology research and screening and validating biomarker and other methods, especially potentially less imaging methods to prevent the exposure. We recommended the working off-site that I think all of us have gotten comfortable with, and certainly all of our experience with the pandemic will help modify research strategies and such. So Dr. Addison, do you have anything else that you'd like to add on that front?
No, I think this is well put, and I think kind of as we saw at the Cancer Consortium, thinking more about multi-center approaches to really study outcomes amongst patients who may have been exposed to COVID-19 is really going to be the future as far as cardio-oncology over the next 2 or 3 years as it relates to COVID-19 as we enter into the year 2021.
Thanks.
Courtney, Dan, and St. Louis, thank you all for doing this. This is really a great summary, and I appreciate Jennifer, Daniel, and Arjun getting on. I do think that, you know, it's interesting that you could think of this as an approach to COVID-19, but honestly, I don't think there's going to be a COVID-20 or a COVID-21, or there'll be some other virus, or, you know, who knows what sort of infectious complications we're going to have to deal with in the future. So I don't really think that this is limited to COVID-19 by any stretch, and how we adapt to a high risk environment or a lower risk environment is going to be very important. But I would be curious what Jennifer has to say. You know, we had many situations where people with hematologic malignancies were in the course of their treatment, and some of them had recently had a stem cell transplant or something along that line. And, you know, their risk of exposure was very high, but their cancer treatment couldn't pause. They have to continue on with whatever they're going through. And I don't, you know, honestly, our hematology and oncology colleagues, I think there was a period of time where they did a lot of virtual things, but for the most part, I think nothing changed about their treatment paradigms. They just tried to limit exposure. But what would be your experience about that?
Yeah, I agree with what you're saying. You know, many times, obviously, our patients can't wait to get their stem cell transplant, or if they've already had a transplant, certainly we can't make their immune system recover faster. I think one positive is that our patients already seem to be very conditioned to avoid infection, and many of them were wearing N95 masks before COVID-19 ever started, and, you know, staying out of groups of people and things like that. So I think that actually has helped in terms of exposure to the virus, just as behavioral modifications that they were already making. One thing that we, and I think most other places, did at the beginning is try to put a pause on some of our autologous stem cell transplants. Allos that were not urgently needed were put on hold too. We're back to doing things at full speed, as I think most places are right now, with just, you know, really strong consideration for limiting the number of visits patients are making to the hospital, more so to avoid them stopping at rest areas and staying in hotels rather than actually keeping them out of the clinic itself. And I agree with, you know, everything that Courtney was saying related to how cardio-oncology is changing. We were and are doing the same things. Definitely people have to come in for infusion visits. They have to get CAT scans sometimes. But those patients on oral therapy, we're trying to do as many telehealth visits as we can, especially for patients that live far away, with local labs, or sometimes even home health care, going out to draw labs in people's houses. That's been actually a really big help. And then clinical trials, stopped for a period of time at most places. And I think most places, even ones that are still experiencing a lot of spread right now, are trying to get back to starting their clinical trials and continuing to run them, just because these things can't wait.
Yeah.
Arjun, I think, you've published quite a lot on CAR T therapy and other more intense treatment paradigms that are happening. Do you routinely check a COVID-19 test before you initiate such therapy, or what is your general practice?
You're muted, Arjun.
Sorry, thanks, Dan. That's a great question. So the hematologists do actually routinely screen for more intense therapies, such as if they are giving CAR T, with the likelihood of CRS developing and the subsequent consequence of that. All of these patients are kind of screened beforehand. But for more routine therapies, they do have a screen, but they're not necessarily isolated for a 2-week period, which the more intense patients, such as for stem cell therapy, are.
And then what would you say about checkpoint inhibitor therapy? Do you think that they should be screened for COVID-19 before they're given it, or what do you think?
Yeah, so that's a great question. So they're not routinely being screened for this at the moment in our center, at least. Again, it may be on a case-by-case basis if they feel that the patient is at high risk for developing complications, that's done, but not routinely just before they're given checkpoint inhibitor therapy. At the moment, it's more reserved for those who are undergoing stem cell transplantation or those who are undergoing CAR T therapy.
We actually at Ohio State, and I think many other cancer centers in the U.S. are screening patients before cycles of chemo. And we also are screening everybody as they're getting admitted to the hospital too. And then, if people come back positive, asymptomatic, there's a big discussion. Of course, something very intensive, like a stem cell transplant or CAR T cells, probably would get put on hold. Sometimes we, do a risk-benefit ratio for less intensive chemotherapy.
Mm-hmm. Yeah. So I think we kind of skipped ahead on some of the topics we were planning on getting to. So I'm going to briefly go through a little bit to turn back to what we're talking about, our repurposing, and then we'll go into our Ohio State experience more specifically. So in the last couple of weeks, we just published repurposing immunomodulatory therapies against COVID-19. At the end of May, I did a systematic evaluation of some of the clinical trials on clinicaltrials.gov, and found that about 141 were looking at repurposed drugs, specifically looking at inflammation and COVID-19. So most of these were anti-inflammatory, some complement-based, some 26 were anti-cancer, and then a few looking at anti-rejection. So these studies are happening all over the world, the majority being in the United States, followed by China, France, Spain, and Italy, and a large stretch that are doing have less than 5 trials looking specifically at repurposed drugs. So these are common in our ongoing investigations. So looking at the anti-inflammatory side of things, there's a lot of, the red here indicates an approved therapy that's and then the open ones, the white background, indicates that they're currently under investigation. Some of the highlights here is the IL-1Bs, this anakinra and canakinumab. These specifically have some positive cardiovascular effects. Some of the New England Journal papers from a few years ago looking at decreased cardiovascular events after myocardial infarction. And then the JAK-STAT inhibitors, they also use a lot in the oncology and hematology sphere. But in addition to decreasing inflammation, baricitinib in particular is predicted to help decrease viral and endocytosis within cells based on inhibition of a NAC inhibitor, so multiple aspects. And then complement, these repurposed drugs are typically used for atypical hemolytic uremic syndrome. They're being investigated in graft versus host. There's 2 approved, eculizumab and ravulizumab, and then many others under investigation. And these have potent, as part of the innate immune system, can be activated through antibody, a lectin pathway, and an alternative pathway. But the common pathway can both induce microvascular thrombosis diffusely, as well as be a potent recruiter for inflammation. And then for the anti-cancer therapies, there's a lot of different ones that are being repurposed for COVID-19. And I think some of that is because of the overlap with what we're seeing with the consequences. So a lot of inflammation, a lot of the same aspects that promote angiogenesis and would make that a target, increasing vascular permeability, will promote tissue inflammation locally, especially in the lungs, and targeting that could potentially improve some of the things we see in COVID-19. And I think, and specifically the BTK inhibitors is something near and dear to OSU's clinical investigations. There are some studies showing that it helps improve the recovery in flu models, as well as a role downstream of toll-like receptors, which can be, with the virus can actually be activated by, and then BTK is downstream of the MYD88. And Dr. Woyach, do you have anything to add for the BTK and anti-cancer treatments for COVID?
No, not really. That was a good summary. I think, certainly there's been some clinical data now with BTK inhibitors, specifically ibrutinib in some patients who are already taking it, and acalabrutinib in a prospective non-trial manner. So those are some things that we're very excited about, and I know a lot of places are as well.
Oh. So I think for the cardio-oncology community, it's important to recognize that a lot of these drugs are being trialed at your institutions, looking specifically for COVID-19. And we do recognize that even on a short-term basis, things like arrhythmias or hypertension, thromboembolism can occur with this use, and should be on our differential and should help educate our colleagues along those lines. So Dr. Addison, do you have anything you'd like to add along those?
Yeah, no, I think that's a great summary. And I think, again, for the audience at hand, these trials are going on right now, and they're going on all across the world. And so we're going to see this more and more. We're going to be called about these patients who may have potential questionable effects related to therapies that they're on, again, with the goal of mitigating COVID-19. So I think enhanced vigilance will only be of relevance to our population going forward.
And especially if you're seeing that they're just on a trial that's an acronym, investigating that it might be what drug that they potentially are on, or if it's placebo or not, I think can really help inform our consults in this area. So for the next half, we're going to be focusing on the Trans-Continental perspective. We'll talk, like I said, specifically about the OSU and Ohio State experience, and then Arjun will be speaking about his UK experience. So I think many people are familiar with this graph. This is taken from the Johns Hopkins website, looking at the US. We're here in the orange with an initial peak, a plateau, and then over the summer a second peak, and we're now on a downslope plateau range. So in the US, it's very heterogeneous, so the experiences of a particular place is going to be dramatically different from one to another. A lot of people know about New York and the experience in the hotspots, or like Arizona more recently, but it's really a state-by-state pattern. So on the East Coast, you see these early peaks. In the South, you're seeing the later peaks. And then here in Ohio, we do have a smaller population than some of these other states, but a much less intense curve. And here the red indicates a average over the last week that's decreasing versus green with increasing intensity of the increasing case diagnosis rates. So in Ohio in particular, I like this graph from Johns Hopkins because it shows the policy decisions and how those overlay with the case diagnosis. So we had a lot of early and restrictive closings back in March, and I think that definitely tailored our and mitigated the peak. We do have this peak here that for us at Ohio State was representative of our peak because that was the outbreaks in our prisons, and that did make national headlines at least. And we care for our prison populations exclusively in Ohio. So that definitely was more of our peak resource utilization. And since the summer when we had the opening, we do have increases, but this is now spread across Ohio, and we're much more at a stable position and have a lot of policies in place. So changes at OSU specifically, in March and through mid-May was the most restrictive period. We initially had limited COVID-19 testing, and through the awesome collaborations with our basic science and research colleagues, we're able to ramp that up pretty rapidly. We developed an N95 recycling program with Battelle, which is literally across the street, and that really allayed any concerns about having not having enough PPE. We had dedicated COVID units in this time, and we're doing screenings for all of our staff. Changes specifically to cardio-oncology was, of course, the telehealth and e-consults, avoiding in-person meetings and conferences. We had almost no elective testing, surgeries, or procedures, especially at the beginning, and extensive triage protocols for case priorities when it came to cardiology. That said, some of the only tests that we routinely let through were prior to starting chemotherapy. Those were always, those imaging studies were always completed. And then we had a lot of changes and a lot of talks and meetings looking at COVID-19 focused research efforts, changing the infrastructure, changing the support, releasing a lot of monetary funds available for this research, and really changing our research priorities. So Dr. Addison and Dr. Woyach, would you like to add about some of the early changes at OSU?
Yeah, again, Courtney, I thought that was excellent, and really it was all hands on deck as far as the approach early on. I think we had to do that for our patients. Our patients are very vulnerable. I think, as you alluded to, a multi-pronged approach was really the right way to go. And God forbid if there's another major peak, we'll do it again. But at least for now, we're trying to best accommodate to the circumstance to really get our patients back, to care for them adequately, and really get them back involved and rolling as they should. Mm-hmm. And Dr. Woyach.
I agree. I think the other thing that was initially in place was no visitors throughout the entire hospital system, which has been very difficult, I think, over the whole hospital, but I think especially our cancer patients. That's become less restrictive recently with the inpatients, and then on a case-by-case basis for outpatients too.
Right. So talking about now June onwards was when we have kind of gotten to, I think, a new normal and back to more of a baseline operating capacity at OSU. So we now test all of our inpatients and everyone pre-procedure for COVID-19. So we have, for everyone in our hospital, patient-wise, we know their status. The COVID patients are now not limited to specific units, so it is, there might be one or two on a floor depending upon their primary complaint, like if they belong in our heart hospital versus the cancer hospital. For COVID-19 patients, we still have a lot of restrictions. So we have video monitors in all the rooms so we can have easy two-way conversations. We still do e-consults on the cardiology side of things as much as possible to limit going in and out of those rooms. And we still have really strict triage protocols for when do we need a cardiac imaging or other procedure. That said, now for cardio-oncology, we're still avoiding in-person meetings and conferences, but we've brought back in-person visits, an outpatient setting as well as telehealth, but are being conscious of travel and what needs can be done telehealth versus in person. We have now are completely back up to normal imaging and procedure volumes. And I think that has alleviated a lot of the delays that we were experiencing in the beginning, or deferring some care or some procedures. We do mask and eye shields for all patients encounters, and I think the research enterprise is now completely up and running, including even having some undergrads in our labs with appropriate social distancing. But there definitely are new our Comprehensive Cancer Center policies, as well as research priorities that have changed. And so with that, I want to talk about a case that I think reflects the fallout, especially not in the intense hotspot intense COVID-19 hotspots. So, and what we're seeing with cardio-oncology. So this is a patient who was referred for multiple myeloma, was complicated by AL amyloidosis with renal involvement. He first presented to his nephrologist in September of last year with frothy urine, bilateral lower extremity edema, increased creatinine, and workup revealed elevated free light chains. His nephrologist initiated doing a kidney biopsy that found amyloidosis. No obvious lytic bone lesions on a skeletal survey, but did have abnormalities in his plasma cells count and from the bone marrow biopsy. So in November, a couple weeks after this workup, he saw us for further management. He complained that he was getting tired easily, difficulty sleeping, back and shoulder pain, some new numbness and tingling, and his physical exam was consistent with that. And his labs were fairly unremarkable, a mild anemia, an elevated creatinine that was worsening, now 2.5. Troponin wasn't undetectable, but it wasn't positive by our standards. He did have an elevated NT-proBNP. So his background, as other medical history, coronary artery disease, he had an inferior infarct in the past, 5 years prior with the coronary artery bypass, hyperlipidemia, hypertension, rheumatoid arthritis, hypothyroidism. Family history was fairly unremarkable, or not unremarkable. He had cancer in his sisters and his father, unknown types. His daughters, though, didn't have any issues. Married, liked to play golf, no alcohol, tobacco, or other drug use. Medications, he was on Humira after a long history of methotrexate for his rheumatoid arthritis. And then for his CAD, he was on an aspirin, a statin, a beta blocker, and then Synthroid. So for his clinical course, he saw us. He started on cyclophosphamide, bortezomib, dexamethasone for the multiple myeloma and amyloidosis. And the plan was to have him follow up in 4 months, see how he was doing, and if he had a good response, talk about a stem cell transplant. That was scheduled in March. So he had 4 cycles of CyBOR-D. He had good biomarker improvement, but like Dr. Woyach had said earlier, the stem cell transplant discussion was deferred completely due to COVID-19. For someone that was stable, otherwise it wasn't urgent. We were still trying to figure out our policies and procedures and risk mitigation, so it was deferred. So in June, and this is when we were opening up and getting back to our baseline, he now had a couple more cycles of chemotherapy, was feeling great, and he was wanting a stem cell transplant and requested an evaluation for this. So in July, a few weeks after that visit, he went through all of the pre-procedure evaluations. They had stem cell collection, but a few days later, he developed a new shortness of breath. So they ordered a CT scan of his chest as well as a cardiac MRI and placed a referral to us. So I'll have Dr. Addison talk a little bit more about some of the MRI findings here.
Thank you, Courtney. So really here we have a T1 pre-contrast map, or basically native T1, as many of us are familiar with. And the actual value is derived largely from the septal measurement here is near 1070, which many of us know is not the most impressive for cardiac amyloidosis. However, it is relatively on the higher end of the spectrum. Similarly, the ECV, extracellular volume fraction, which is a marker of diffuse interstitial fibrosis slash edema, was actually 29% for this gentleman. And again, that's actually a mildly elevated value, borderline mildly elevated value. So overall, abnormal, but not necessarily the most impressive for cardiac amyloid in terms of myocardial involvement.
Yep. So like Dr. Addison said, on our evaluation, though, as far as a pre-transplant, we didn't feel like any of these abnormalities precluded him undergoing the stem cell transplant. He also did have a preserved ejection fraction, but evidence of a prior infarct on his inferior wall with severe hypokinesis in that region. What did delay his transplant, though, was a moderate new left-sided pleural effusion. So pulmonologist recommended a thoracentesis, which found some bloody exudate, but no malignancy, and the cultures were negative. So after that workup, it was felt that he could go ahead and undergo a stem cell transplant, which is what is happening this week for him. But for him, because of COVID-19, the stem cell transplant was likely delayed 4 to 5 months. And that meant that he had additional cycles of chemotherapy, probably at least double the number of cycles. He got new symptoms with this, with a pleural effusion, multiple imaging tests, multiple trips to Ohio State, and an additional procedure all before. And while this isn't the most intellectually challenging of cardio-oncology cases, I think it does reflect the kind of domino effect of what happens when we delay something like stem cell transplant for COVID-19. So any other things you'd like to add, Dr. Woyach?
Nope.
All right. So with that, I want to move on to Arjun's talk. So thank everyone, our collaborators within the OSU Cancer Center, our collaborating institutions, and of course the patients and families we treat at OSU. And then this is our cardio-oncology team, as well as our places that we work. So thank you, Arjun. Still on mute.
Could I check that you can see my screen?
Yes.
Okay, great. Thanks very much, Courtney, Dan, and Jennifer for laying the scene, really. And I thought that we had collaborated on that great paper led by Courtney and Daniel about cardio-oncology care in the time of COVID, and it would be useful really just to give a bit of an idea about the UK experience. So we really had a number of different phases to the response in the medical fraternity. So I think back to January when COVID-19 entered the mainstream, probably more for healthcare professionals than for the rest of general society. In February, however, we really saw that there were massive changes to cardiology practice in China and Italy. You know, these countries were hit hard at the beginning. In March, we in the UK realized that COVID was coming. It was in Italy. It was coming to us. And at that time, we really undertook massive changes to the normal workforce planning in the National Health Service, just in preparation for what was to come. And this is probably best illustrated by this quote by one of the doctors in Italy who faced this in March. And the quote was, "There are no more surgeons, urologists, orthopedists. We are only doctors who suddenly become part of a single team to face the tsunami that has overwhelmed us." And this is really what happened in the UK as well. We ceased to be cardiologists or gastroenterologists or whatever the specialty. And this happened to me as well. I was redeployed to one of our sister hospitals, and I was working as a general physician, and that's me there. And I was just basically just seeing COVID patients, just doing general medicine, not doing any cardiology. And you know, this obviously has big implications for cardiology services and cardio-oncology services, and I'll come on to that. One of the advantages where you can see on the right side, that was our relaxation room. It was very nice. We even had stewards from British Airways come and give us some relaxation therapy. So there were some advantages. So what were the, what was the impact on cancer services in the UK? Now, this is something that was produced by Cancer Research UK, which is one of the biggest cancer charities in the country. And this document, this was published in April, just looked to see how COVID was affecting cancer services. And from that document, they really talked about how cancer treatment had been severely disrupted. They talked about how screening for cancer had been disrupted. And they also talked about the people who had vague symptoms, such as weight loss, who may have cancer. These patients were not being diagnosed because of a lack of easy access to their primary care physician and a lack of tests in secondary care. So, this had an impact on cancer deaths as well. So this was published in the Lancet Oncology, and this group tried to model the effect of COVID-19 on cancer deaths due to a delay in diagnosis. And what they really showed was that substantial increases in the number of avoidable cancer deaths were to be expected because of COVID-19, and there were a number of factors due to this. So how did we in cardiology respond? So apart from the redeployment, the NHS really tried to streamline services. They produced this document, and the emphasis, as really has been already explained very nicely by Courtney, very much mirrored what happened in the US. There was an emphasis on acute cardiac care, and there was an emphasis on trying to keep patients in the community unless they really needed to come to hospital. So this was published in March. And this is a later document that I will come on to a bit later. This was produced by the British Cardiovascular Society in August. And this really looked at the changes that had taken place due to COVID, the changes that had taken place across the board and in cardiology, and really how we should move forward as a specialty in the UK in a COVID positive world. And I'll come on to this. So I'll just cover very briefly three main areas in which cardio-oncology care changed. And this document has already been referenced by Courtney. So this is a great document by ICOS on cardio-oncology care in the time of COVID. And we did something similar. So in our hospital at University College London and at Bart's Heart Centre, we actually continued on with our cardio-oncology clinics. A lot of the general cardiology clinics and a lot of other clinics had stopped. We very much followed a very similar model on risk stratifying the patients, trying to determine how many patients could safely be postponed their clinic appointments, how many patients needed to be seen urgently. And again, this was very much according to their risk profile. We also moved on to a model of virtual clinics, telehealth, while maintaining very few face-to-face visits. So we didn't completely stop face-to-face visits, but this had significantly reduced the number. So in terms of the virtual consultations and the telemedicine consultation, this is from that document by the British Cardiovascular Society. And really, they recognize that virtual consultation should be the norm in primary care and also for secondary care in those who don't require a face-to-face attendance. They also commented that face-to-face attendances should only occur at the right time, in the right environment, with the right people present. So really trying to specify that it should only be for important situations where it's essential that it's face-to-face. They also commented on the fact that really within a very rapid time frame, in primary care and in secondary care, it moved to a virtual model, and also MDT meetings also took place in a virtual setting. And this happened very rapidly. This again has also been explained very well in the ICOS document, and they've really outlined the pros and cons of different types of virtual meetings, the e-consultation, the telephone, the video, and the face-to-face consultation, with the pros and cons. And I'm sure all of us on the call have seen this already. So the last major part of changing cardio-oncology care would really be the tests. And as we all know, echocardiographic screening and surveillance scans do play a pivotal role in cardio-oncology practice. And this was a brief document that was produced by the European Society of Cardiology Cardio-Oncology Council. And what we did in our local practice was something similar. We decreased the frequency of monitoring for the low-risk patients, and we also introduced more biomarker monitoring. So really, just to summarize what I think has changed with COVID, or how our practice has been modified due to this in cardio-oncology. I think it's actually led to closer collaboration with cardio-oncology colleagues across the world. I mean, we do collaborate with groups across the world, you know, we all do, but I think, you know, we were all very anxious about, you know, what this meant for our own practice. And we were initially contacting people in Italy, and then when COVID had hit us, we were getting a lot of contact from people in the US, where things were happening just a little bit behind us in Europe. So it really, I think, increased the collaboration, led to the paper that's been presented by Courtney and others. Again, Courtney has already touched upon this. We use drugs that we use in CAR-T therapies, such as tocilizumab. These drugs were being used in the research setting for potentially treating a COVID-19 related cytokine storm. So again, producing this interface between cardio-oncology and COVID. Now, for those who work in the UK, this will not come as a surprise, but NHS IT infrastructure is notoriously leaden-footed, very slow to react. It was amazing how, with a national emergency, a pandemic, how suddenly things were moving. And we've really dragged the NHS IT infrastructure, I don't know about 21st century, but at least late 20th century, maybe beginning of 21st century now. And I've already mentioned this really has facilitated better MDT working. We have oncologists and cardiologists who work across a number of different hospitals. Now they can remotely access these meetings. We can all still get together. And this has really improved the quality of our MDTs. Again, looking at it from the perspective of us as physicians and us with families, it's made flexible working, remote working more acceptable and normal in certain situations. You can do certain clinics from home if you don't need to come in to see any patients. So this has really changed, the life balance, work-life balance for some people in a good way. We've already talked about this. Echocardiography is one of the high-risk procedures when it comes to the spread of COVID, the close contact with the patient. COVID-19 really led to focused echoes, targeted echoes, and this is of course very relevant when it comes to surveillance echoes in cardio-oncology. We're looking more at cardiac function rather than anything else. And again, I did touch on this. It's led to more biomarker monitoring and integration into cardio-oncology practice. Now, of course, the pros and cons of this are a separate talk, and I won't get into this. But this has been one of the consequences. So with that, I'd just like to thank the other members of the University College London team and the Bart's Heart Centre team. It was a really big experience for all of us. It continues to be a struggle for all of us across the world. And without our colleagues and the other members of the team, this would be very difficult. So my thanks to all of them.
Excuse me, would you please go to previous slide? last slide, if it's possible. If it's possible.
Is it this slide?
No, the slide before. Thank you so much. Thank you.
This slide?
No, the slide after that, please. Next one. No. Yes, this is
slide 44.
Yes. This slide. Thank you. Yeah, might have a question.
Sure.
Yes.
Excuse me, as you know, in pandemic COVID-19, as I see in Iran, I'm Dr. Shekachizadeh from Iran. I am in Azara hospital in Isfahan, the center of the center for COVID-19. I see that many patients, if I not say every patient, we have positive troponin in our patient because of, for example, respiratory distress. We have mild positive troponin, and how can it help me to manage the oncologic patient in COVID-19? As we know, in fever, in respiratory distress, and many reasons we can have a mild positive troponin. Would you explain how can it help me in oncologic patients?
Sure. I mean, I can. So we know definitely that there can be a troponin rise in COVID, but this was more for those patients where we're not suspecting COVID. This is more for those patients who would be on Herceptin, those patients who would be on anthracyclines. We would be routinely monitoring them through the course of their treatment with echocardiography. Because we were less able to access these investigations, it was sometimes easier to obtain blood tests such as troponin, such as NT-proBNP, when they were coming for their chemotherapy or their immune therapy via the oncologist. So this was a compromise where we were monitoring their biomarkers to see if there were elevations. Again, this is really more talking about those patients where we're not suspecting they have active COVID.
Okay, thank you. I think for COVID-19, yes, I get the point. Thanks.
To that point, I would probably add, and that was a great answer by Dr. Ghosh. The data that we have available are not cancer specific as far as the value of troponin elevation. And so to interpret it in the context of a patient with cancer, it's a little bit more of a challenge beyond just understanding that they're likely at higher risk for more adverse outcomes.
Yes, of course. Thanks.
Well, this has been a fantastic presentation. Thank you all for the international perspectives. I think we need to wrap up there, and I'm sure if anybody has follow-up questions, our panelists would be more than happy to interact by email. So thank you all for your participation today, and we hope you'll join us again next week, same time. Thank you to our panelists in particular.
Thank you. Thank you for having us. Honor. Thank you.
Thank you all.